In this section, we are going to discuss class 2 antiarrhythmic drugs. As we all know, these drugs include beta blockers. So if this is a cell, so intracellular levels of potassium are high and extracellular levels of sodium are high. If this is a beta receptor and in the sarcoplasmic reticulum, there are high levels of calcium ions. So going from outside to inside, we can remember these classes of drugs. So class 2 drugs, they are beta blockers. Now, as we all know, beta 1 receptors are present predominantly in the heart. They are present in both SA node as well as in the AV node. Now, the effect of beta receptors on SA node will be prominent on SA node as well as on AV node. In the SA node, these beta blockers, they will decrease the rise of the rate of rise in the prepotential. As a result, there will be decreased heart rate. So these drugs can be used in several tachyarrhythmias. In tachycardia, we can use these drugs to decrease the heart rate. Similarly, on the AV node, the effect of these drugs is quite similar. It decreases conduction through the AV node, and this effect can be useful in various arrhythmias. Now, there are a number of beta blockers. However, beta blockers which are mainly used for antiarrhythmic action, they include propranolol, metoprolol, and esmolol. Now, an important point to be noted is that esmolol is the shortest acting beta blocker. Therefore, it is used in several cases of acute exacerbations of various arrhythmias. Now, let us discuss the uses of these drugs. So, these drugs, propranolol, metoprolol, esmolol, they are the drug of choice in case of various arrhythmias. For example, beta blockers, they are the drug of choice in case of ventricular tachycardia, which is idiopathic in nature. They are also drug of choice in ventricular premature beats because they will depress the ectopic foci, and they can also be used in long QT syndrome, that's in Torsades de Pontis arrhythmia. They are the drug of choice in this case, and they are also the drug of choice for rate control in atrial fibrillation. So for the management of patients of atrial fibrillation, there are two aspects of management. So for them, we give drugs for rate control and the drugs for rhythm control. So for rate control in patients of atrial fibrillation, the main drugs are the beta blockers, and for rhythm control, we mainly use class 3 antiarrhythmic drugs, which we are going to discuss after this. So they are used in idiopathic ventricular tachycardia, premature beats, torsades, and rate control in atrial fibrillation. They can also be used in catecholamine-induced tachyarrhythmias. Now, catecholamine-induced tachyarrhythmias can occur as a result of pheochromocytoma or after exercise, after stress, etc. So they'll cause release of catecholamines, which will stimulate beta receptors and cause these arrhythmias. So we need to give beta blockers. Now, uh, in case of a stable patient, we use the preferred drug is metoprolol, whereas esmolol is used in unstable patients. So in unstable patient, he can have an acute attack almost at any time. So to prevent that acute exacerbation, esmolol is preferred. Esmolol is also preferred. It's also drug of choice. Sorry, not drug of choice. It's also the preferred drug in anesthetic agent induced arrhythmias. So whenever we use anesthetic agents such as halothane or cyclopropane, these anesthetic agents, they cause a release of catecholamines in our body, and those catecholamines, they will act on beta receptors and they will induce various arrhythmias. So for treating these arrhythmias, we use beta blockers, mainly esmolol. In case of an acute attack of supraventricular tachycardia or paroxysmal supraventricular tachycardia, the preferred drug of choice is IV adenosine, because IV adenosine is a short-acting drug and it has direct depressant action on AV node. So because of its direct depressant action and short-acting nature, it is the drug of choice in this case. However, if due to some reason IV adenosine is not available, then we can give beta blockers, and the beta blocker of choice in this case is esmolol, because esmolol is the shortest acting beta blocker, so it can be useful in acute exacerbation. Now, if due to some reason beta blocker is also not available, then we can use parasympathomimetic drugs, and the preferred drug is adrophonium, again because of its short acting nature, and it's going to produce the same effect, that's it's going to depress the AV node. Now let us discuss class 3 drugs. As we all know, class 3 drugs, they are potassium channel blockers. So let us see the effect of potassium channel blockade on the action potential curve. So if this is action potential curve, this is depolarization, plateau, and the repolarization. Now because of block in potassium channels, there is going to be delay in repolarization, and as a result the duration from the beginning of action potential to the end of repolarization is going to increase. In other words, there is going to be prolongation of QT interval on an ECG. Now if we take a look at ECG, this is the P wave, QRS complex and T wave. So right from the beginning of Q wave, that's ventricular depolarization, to the end of T wave, that's after the repolarization, the QT interval, it's going to increase by the use of these drugs. In other words, there is going to be an increased risk of Torsades de Pontis arrhythmia, which is characterized by prolonged QT interval. So the drugs of class 1A and class 3, they cause increase in QT interval and increase the risk of Torsades. Now the drugs of this class, they can be remembered by a single acronym BINDAS. So B stands for beryllium, I I stands for ibutylide, so N doesn't stand for anything. D stands for dronidarone, and another drug is dofetilide. A stands for amiodarone, and S stands for sotalol. So these are drugs included in class 3, and the drug ibutylide, it has maximum risk of causing Torsades de Pontis arrhythmia, and the drug amiodarone, it has least or minimum risk of causing this arrhythmia because it also blocks this calcium channel. So we are going to discuss it separately when we discuss the individual drug. Sotalol is a beta blocker, however its anti-arrhythmic action is mainly because of potassium channel blockade. The most important drug in this class is amiodarone, so we are going to discuss these drugs in detail starting with amiodarone. Amiodarone, it's the longest acting anti-arrhythmic drug, and the duration of action, it's almost more than 3 to 8 weeks. That's the duration of action is almost 53 days. So it's the longest acting anti-arrhythmic drug with a duration of action of 53 days. Now this drug amiodarone, it has an oral bioavailability of almost 35 to 65%, and once when given orally, it has slow onset of action, but if given by IV route, then it can produce rapid action, and it has high volume of distribution, so loading dose is required for it to produce effect, and it gets distributed to muscles and fat, from where it's released slowly into the circulation and it produces its effect. Eventually it is metabolized in liver by the microsomal enzyme cytochrome P3A4, and it's excreted in bile. Its half-life is almost 53 days. Now let's talk about mechanism of action of amiodarone. Okay, so it's 3 to 8 weeks. Okay. So amiodarone, it possesses the mechanism of action of all the classes of drugs. So amiodarone, it possesses the mechanism of action of class 1 drugs, class 2 drugs, class 3 drugs, as well as class 4 drugs. That means amiodarone, it can block sodium channels. It also acts as a beta blocker, and in fact it also has some alpha blocking property. It also acts as a potassium channel blocker and a calcium channel blocker, and because of this blockade of calcium channels, this amiodarone, it tends to decrease the duration of plateau, and which tends to decrease the QT interval. Now because of blocking potassium channels, it tends to increase QT interval, and because of decreasing calcium channels, it tends to decrease the QT interval. So this amiodarone, it has the least risk of causing Torsades de Pontis arrhythmia because it also blocks calcium channels. Now, because of this broad mechanism of action of amiodarone, it's the widest spectrum anti-arrhythmic drug that's used. However, it's not used in case of Torsades de Pontis arrhythmia. Otherwise, it can be used almost in any type of arrhythmia. Now, now let us discuss the uses of amiodarone. Amiodarone can be used in any type of arrhythmia except Torsades because of risk of causing Torsades. And amiodarone is the drug of choice for the treatment of ventricular tachycardia and ventricular fibrillation. However, if these conditions occur after myocardial infarction, then in that case the drug of choice is lidocaine and not amiodarone, because lidocaine, it exerts its effect better on ischemic tissues as compared to amiodarone. Now amiodarone, it's also the drug of choice for rhythm control in the patients of atrial fibrillation or flutter. So we already discussed that for rate control in case of atrial fibrillation, the drug of choice is beta blockers, but in rhythm control, the drug of choice is amiodarone. Now, because amiodarone, it's a long-acting drug, its half-life is very long, almost 53 days. Therefore, it can be used in prophylactic therapy. Therefore, it also has prophylactic use for various types of arrhythmias. Now, amiodarone, as it's the most widely used anti-arrhythmic drug. However, it produces various adverse reactions in body. Now let us discuss these adverse reactions. So first adverse effect is on the thyroid gland. It can cause increase in thyroid hormones or decrease in, so it can cause hypothyroidism or hyperthyroidism. Now it depends on the geographical area where where the patient resides. So if the patient is coming from a new thyroid zone, then the effect will be hypothyroidism, and if the patient is coming from an iodine deficient zone such as a hilly region, then the effect will be hyperthyroidism. Now in and now if we look at the name of amiodarone, it contains iodine. That means amiodarone, it contains almost 40% of iodine, and when this amiodarone is given to a euthyroid patient, so because of excess iodine there will be decrease in sense of thyroid hormones resulting in hypothyroidism. However, if it's given to an iodine deficient patient, then there will be excess synthesis of thyroid hormones which results in hyperthyroidism. Another effect is on the myocardium. It can cause myocarditis and decrease the myocardial contractility, thus causing myocardial depression. Myocardial depression will be obviously because of block in sodium channels, potassium and calcium channels. Now, another important adverse effect of amiodarone is on the lungs. It causes pulmonary fibrosis. And this pulmonary fibrosis is mainly because of damage to type 2 pneumocytes. Now, there are other drugs which can cause pulmonary fibrosis. These include drugs such as some anti-cancer drugs such as bleomycin and cyclophosphamide, methotrexate, etc. Now, these drugs cause pulmonary fibrosis by causing damage to type 1 pneumocytes. So the difference is in the type of pneumocyte damage that these drugs cause. Amiodarone causes type 2 pneumocyte damage. However, these other drugs, they cause type 1 pneumocyte damage and all result in pulmonary fibrosis. Another important adverse effect of amiodarone is on the liver. Amiodarone can cause formation of granulomas in the liver and thus lead to hepatotoxicity. Therefore, amiodarone is also a hepatotoxic drug. Another important adverse effect is on the cornea. Amiodarone can cause corneal depositions, and these depositions are sometimes arranged in a particular fashion. So, if uh, if this is a pupil, so these corneal depositions can be arranged in a whirl-like fashion. So this pattern is called as whirl-like pattern. So there is whirl-like pattern of corneal depositions. The technical term used for it is called as vortex keratopathy, and this vortex keratopathy is also seen in a type of glycogen storage disease, that's in Fabry's disease. It's also seen in Fabry's disease. Amiodarone can cause other adverse effects on skin. For example, amiodarone can cause photosensitivity, that is, there will be development of rash on the skin on exposure to sunlight. Amiodarone can also cause bluish coloration or bluish pigmentation of skin, which is called as ceruloderma. So ceruloderma is the bluish coloration of skin, which is caused due to amiodarone. It's also called as blue man syndrome. Now there is another condition which is a similar condition, which is called as red man syndrome. So red man syndrome is caused due to vancomycin, whereas blue man syndrome or ceruloderma is caused due to amiodarone. Now let's take a look at interactions of amiodarone. So amiodarone should not be given with drugs such as digoxin and warfarin, because amiodarone will decrease the renal clearance of these drugs, digoxin and warfarin, and which will result in decreased excretion of these drugs and thus increased plasma levels of digoxin and warfarin, and it can cause toxicity. So it should not be used along with these drugs. Amiodarone should also not be used along with beta blockers and calcium channel blockers, because beta blockers and calcium channel blockers, they have a depressant action on AV node, and amiodarone can produce both these effects. So because of synergistic action, it can result in various degrees of AV block. Amiodarone should not be used along with inducers of cytochrome P3A4 or along with inhibitors of cytochrome P3A4. So inducers of cytochrome P3A4 can result in ineffectiveness of amiodarone, and inhibitors of cytochrome P3A4, they can result in toxicity of amiodarone. So if we use inhibitors, we have to decrease the dose first. Now let's take a look at other drugs of this class. So dronidarone, it's a recently synthesized drug. So if we see the main effects of side effects of amiodarone were due to presence of iodine. So dronidarone is similar to iodine, but it does not contain similar to amiodarone, but it does not contain iodine, so it has less side effects. Remaining effects are same as amiodarone. However, there are some differences. For example, in pharmacokinetics, dronidarone has half-life of only 24 hours. It does not have a long half-life. And dronidarone is active orally, and its absorption increases with food. Therefore, it's advised to take dronidarone along with food. Dronidarone is contraindicated in lactation, pregnancy, and congestive heart failure. The next drug of this class is bretylium. So bretylium was earlier used for the treatment of ventricular fibrillation. Bretylium is called as pharmacological defibrillator or medical defibrillator. So it was earlier used in ventricular fibrillation. However, it produced a side effect, that's hypotension. And for the treatment of bretylium-induced hypotension, the drug used was norepinephrine. Now, these days, bretylium is not used because of availability of electrical defibrillators, and because of advances in technology, this drug is not used. So, now other drugs, in other drugs, we have ibutilide and dofetilide. Ibutilide, it has maximum risk of causing tossade, stupendous arrhythmia, and ibutilide is also the shortest acting drug of this class. Ibutilide, being shortest acting drug, it is used in acute attack of atrial fibrillation. So whenever normally for atrial fibrillation, we use beta blockers, digoxin, etc., and they prevent the transmission of arrhythmia to ventricles. So we maintain the rhythm of the ventricles to normal so that cardiac output can be maintained. However, this ibutilide, it plays a role in restoring the normal sinus rhythm of atria. So it's somewhat different from other drugs. Now, the drug dofetilide, it has properties which are similar to amiodarone and ibutilide. So it can also be used in acute attack of atrial fibrillation and for treatment of other arrhythmias. This dofetilide, it has maximum oral bioavailability, that's 100%.